And we are live. Good morning, good afternoon, good evening, everyone, and welcome to another episode of the Hierarchy Betrayal. I'm Dina Paoloni. I am your co-host, and I'm a career coach, Italian nurse, career coach for international nurses in UK. And I am in this episode with my co-host, Kimberly Maurer. Kimberly, hello. How are you?
Morning. Good morning. I'm so sorry. I was having like computer issues in my mic. I couldn't get it attached.
We are live already.
Okay.
It is okay. It is okay. We have tech
fix my
gremlins. We
eyes.
have all kinds of shit every time, so it's okay.
All good. All good. How are
So
you?
today we are with Kimberly Maurer, my co-host, and we are again with Brittany. Hello, Brittany. How are you?
Hi. Good. I'm fixing my eye bags.
You're so funny. You are so funny. Oh my goodness.
I feel like I'm always like last minute. Last minute, everything just compiles. Okay.
So
you look beautiful. You look beautiful.
Thank you. Thank you. Let me get this out of my hair. All right.
Just a second. I think we just adjust something behind the scene. And hi, Kimberly. How are you?
I'm good. I'm good. It's a beautiful morning. You know, we are above ground, so that's good. 6 feet above ground, whatever they say. What is it that Pitbull says all the time? Every day above ground is a good day. So here we are. And good morning, good evening, good afternoon to everyone who's tuned in today. We appreciate you so very much. And thank you for always supporting and coming with your questions, your comments, just yourself. I love it when y'all show up. It just makes my day. And Dina and I look so forward to this every Sunday. So the conversation is going to be a little bit less laid back today. We're going to be a little bit more serious today in regards to what Brittany has created. And I don't want to call it a controversy, but there is a lot of questions in the background of it. And what exactly and just how much visibility does it put on the nurses? And does it actually show a system that it's broken, or does it just allow it to be even more broken? So Dina, you are moving, and next week we won't be here because you won't have broadband, you won't have internet services.
Yeah.
But tell me, how is all that move going?
Yeah. It's so hard. I'm very tired. I don't know if I look like, but I'm exhausted. But I always really enjoy spend this time with you, Kimberly, with our amazing guests, and with all of you guys. So thank you for coming in today as well. Just a quick remind you, yes, I won't have broadband next week, and so we cannot do the live, but I have difficulty today as well. So in case I experienced the same thing I experienced last Sunday, which was very fun. If you participated, you know the what's going on to the recording. And so if I realize that I can't hear you anymore, everything, you continue, you keep going. Okay, Kimberly, and I figure it out behind the scene what's going on. Yeah,
yes,
so
of course,
it's okay,
of course.
It's a good
we just
compromise. So today we are with Kim. Yeah. So today we are again with Brittany. She's been our guest a few months ago, and today we're gonna talk about data. Who owns the data? If the data the healthcare own is actually the right one to identify problem in nursing or not. It's a very important conversation because now experiencing in this period era of AI and all this new tech revolution innovation, nurses are not really involved in this revolution, even though we are one of the largest professions inside the healthcare system. So, Brittany, if you're ready, I'll bring you back in the studio. Are you ready? Okay. And there we go. Hello, so lovely to
Shazam!
Shazam!
Look at that beautiful girl.
You look outstanding.
Oh
Stunning,
hear
stunning.
me okay?
Someone throw her some flowers.
Yeah, exactly. And I love your neon, your lights behind you inspire.
Oh yes, yeah, thanks. I just like switched it around. Thank you.
You look beautiful, your background look beautiful, and I actually need to adjust the layout. Yeah, but yeah, so do you want to introduce yourself again for people maybe missed your previous episode with us?
Sure. So my name is Brittany Parks. I've been a nurse for long time, 16 years now. My history spans from bedside, from NICU to adult ICU, and then home health, and now doing case management. So I've had a little bit experience across multiple areas of healthcare, gotten to see different perspectives through different lenses, which has kind of led me to where I am today.
That is amazing. Thank you very much. So Kimberly I saw her needed to get out very quickly. So guys, we are already live and can see a few the comment. Let's show some comment while we're waiting. Kimberly, should we? So Dylan, hi there, morning. Thank you for coming again. We are so blessed and happy to have you. Hallie, thank you again for coming. Good morning. Such a lovely to have you here. Dylan, yes, you. I don't know what I bring, but I always bring it, love. Yes, thank you very much. Data, talk very important. It's very important, especially considering that we bring as a professional, a health professional, we bring so much data, but majority of the time we don't own the data. So this is so, I see it's a shame. Good morning, Kenneth. Thank you very much for coming. The tech problem has started early. Kind of, yes and no. I don't know. We'll see. We have a promise that everyone have any problem, the other continue to go with the conversation, and who has technical problems stay on the background. Tanasha, hello. Thank you very much for coming. Good morning, good afternoon, good evening. Corinne, good morning, good afternoon. We are in UK. We are 4 p.m. in the afternoon. So
4 p.m. Oh, yeah, 5 hours ahead.
Yeah, 5 hours ahead. Kenneth, I love when they do conversation with each other, isn't it? Dylan said to Kenneth, yeah, I don't think the napping thing, they profit from the problem, then the patches causes lol. I don't understand. Sorry, English is my second language, so sometimes if you use some idiom or things, I don't understand what you mean. Kimberly, what Dylan is saying?
He's talking about when we have all of these tech issues, you think you fixed it and then that pitch doesn't work and then you still have a lag. Gotcha. You still have the tech gremlins. Yeah, you still have the tech gremlins. So again, thank you, Kenneth, Corinne, Dylan, Atanisha, everybody that's showed up today. We appreciate you. Let's dive in. I'm sorry, I had to cut up for just a second. So let's dive into this. Brittany, first off, thank you, Lovey, for being here. But I want you to explain to us exactly what encouraged you or inspired you to create NurseCapture. And then tell us what exactly it does and what you hope that data will show.
Wait.
People have questions.
Wait, because I asked Brittany to start with a very important things. Yes, we go there. Absolutely. Great question. But I really asked Brittany to tell us which problem she identified that she thought that she needed to bring up with a solution and thought with her innovation. Should we start from the problem first, please?
Do you want to start with the problem first?
Yes, please. Thank you.
Sure. Yeah. So essentially throughout my experience working across all these different fields of healthcare and having these different perspectives and lenses and seeing how things work, don't connect, seeing the patient side, seeing how they see the healthcare system through their perspective. And then also as a caregiver myself. So I cared for my grandmother for 10 years who lived with me. Over this past year, we went through hospice, which was an amazing experience. I got to live through that, but for the last few years, be on the other side of the bed with her as a caregiver. So I think just kind of experiencing and then just paying attention and observing and making connections throughout all of these different views, trying to put myself in other people's positions and see how would I feel if this was happening to me? Because I, as a caregiver, seeing my grandmother go through some of the stuff that she did in the hospital, it was very, very frustrating. So that's just one example. But then also, it's, working in different areas, you're able to after previously working somewhere else, you just start making connections in your brain, right? So this underlying I didn't have words for it at the time, I think it was, but it was like invisible work, because I kept thinking, as I'm working in the bedside, I'm talking with my colleagues, and I'm just thinking about all the different things that we do that don't get accounted for, are never seen. We discuss them among ourselves, but there's no real metric for it. And, so we measure so many things. We measure an abundancy of things in healthcare, but we don't measure the things that get done to make those outcomes what they are. If they're green, good, and where they're at, what certain percentages are. So you might have a leader come down on you and say your barcode scanning percentage is down, just get it back up. But why is it down? Why is it down? So and that's kind of like those little questions kept poking. So, and I finally found some like-minded people that kind of got it. They're like, yeah. And then of course, talking with nurses, it's something that you understand, you live it, you feel it. But there's just no way to kind of get it up. And you feel like maybe leadership or healthcare execs, they don't see it. So that's kind of how the problem came about, kind of in a way without kind of words, but just kind of discussing it more. And then I got connected with a wonderful development company who was like, yes, we can do this. We can probably put something together and get some data out of it, get some actual quantitative data. And that's kind of what led me here today.
Yeah, sorry I interrupt, Kimberly. So yeah, go for your question, answer your question, Kimberly question. So what inspired you? What is your innovation about?
Oh, I'm sorry, I didn't hear. Oh, so Kimberly's question was what NurseCapture is? Yeah. Okay.
Yeah. So just kind of tell us exactly what it is, how it works, how it's utilized. Love you, girl.
Love you too. So basically, we're still in the validation state because we really want this to work and work well. So the idea is that it's an anonymous frontline signal capture that's designed to make the visible, adaptive, and compensatory work conventional healthcare data often misses. So interruptions, information chasing, could be item chasing, coordination workarounds, recovery, anticipatory action, quiet course corrections, the space between the system as designed and the system as actually lived. So the goal is to, create something that is not more charting. And that's kind of, why we're taking the time. And I'm really grateful for my development team and working with me, because we really want to make this something that it's almost like nurses it's not an extra thing, right? Because we already do so much documenting. There's already so many things you have to do. but we need to be able to capture those moments. So the idea is to make something, make an item, make a, we're currently testing a few different things that can catch things in those moments and capture them with low burden, and then eventually see patterns over time. So, yes, in nursing, there's expected to be workarounds and, things like that. Yes, absolutely. That's what nursing is. However, if we find that the same people are doing the same, I'd say more work, because that's not fair either. But, we're finding that we're finding the same signals, we're finding the same gaps across different, units at certain times. Now we have data. Now we have something we can use, right? We can maybe reflect it in a dashboard that can be utilized to restructure, a unit or health or whatever the case may be. But the point is that the data is now available to do something with.
And
that makes sense.
I remember one of the first comments we have under this episode when I put out the event. It was, I don't remember the name of this person, but was a CEO or a high level, and he said that basically healthcare already have the data, and so it's not necessarily the data was is missed, but a kind of leadership. Both of I reply. I probably been a little bit too much stiff, probably. I apologize for that. But what I replied was, well, maybe healthcare has plenty of data, but if it's the wrong data, what we really need to do is evaluate all the nursing work data was missed, because it's behind the scene, and even its chart is not taking in consideration to actually improve workflow or the word itself or team dynamic as well. So we talk about a lot of leadership, but sometimes we come out with leadership solution because of derivative data from the data, not specific data on, for example, team dynamics. So, and you reply in a different way as well. Do you remember?
I do, yes. And I remember thinking he's absolutely right. We don't need more data. We need to know if the data that's being produced is an accurate reflection of the work that's actually happening, right? Exactly. So Kimberly, you have went on LinkedIn. I was like, oh, you just dove right in, and he just kind of just was busting it out. And I was like, oh my gosh, we're not gonna have anything to talk about on Sunday. So there was one thing you brought up, and I think I put the metaphor in one of the comments, and this is kind of like how I, see it, right? Think of that data, those metrics, those outcomes that we see, right? Whether they be HEDIS or whatever the case may be. Think of it as a bridge, a functional like bridge that cars drive on, right? Cars cross through it every day. The bridge looks like it's functioning well. Everything's green. Go. Good. However, underneath that bridge, no one can see it, but there's cracks and there's crevices, and some are wider than others. And you have people under that bridge that are constantly filling in the cracks and filling in the gaps. Some know where the cracks are. Some know where the worst cracks are. And they're quick to move around the bridge to keep the bridge up and functioning. So I kind of think of the things that we're trying to measure and the data we're trying to collect is from those people who are filling those cracks. Because what happens when somebody who knows where all the cracks are, the worst cracks, where it could potentially break, leaves? Then you have, a problem for the bridge potentially, and hopefully someone will step up and start to fill it, which is usually what happens, because nurses are very good at compensating and, just rolling with the punches and pivoting, and we're very effective at that. So that's kind of like my visual metaphor for the work that we're trying to capture.
Absolutely.
So, sorry, Dina, I don't want to cut you off.
No, you go.
So when you talk
I'm just
about
asking you to go.
So So when you talk about this bridge, I instantly think of the leadership, the organization that knows they've been told over and over again what's broken. They've been told over and over again, this isn't working. We need to do better. You need to support us. And people eventually feel like they're just talking into the abyss.
Mhm.
Their voices being unheard, their concerns are going unmet, and there's no collective collaboration. And how can we make this better? It's all about the money, and let's just make money. Just figure it out. How many times have nurses been told, just figure it out? Eventually, that's all we do. That's all we do is we figure it out, because we've talked about it till we're blue in the face. We've brought it to leadership. We've talked to each other. You know, we have these little breakout sessions, and we just vent and talk and talk and talk, and everybody is nodding, but nothing fucking changes. And I hope that with this innovation that you're bringing, that it does plant that seed. It does allow for that growth of everything that we've been talking about for so long, everything that we have been saying to each other, to, you know, and those employment surveys, you know, the employee surveys, where do those go? Where does all of those concerns and those thoughts? You want our opinion? Why even spend the money on marketing those, sending them out, the emails, the time? Who's reading them? Is AI reading them and making a decision on what needs to be fixed and what's broken? Because if that's the case, clearly that's why we're still broken.
That's right.
And until it becomes more of an organization's responsibility to listen to what the people inside those walls are saying and seeing and enduring on a daily basis, I just don't feel like anything's going to change. Because all of us, look at all of us out here on LinkedIn, on this platform alone. I'm not even talking about all the videos and everything you see and all the other social media outlets. There is a lot of chatter. I mean, if you look at it as like the dark web, how many times have we heard, oh, there's a lot of chatter out there today. There's a lot of chatter out there today. You know, and we've had this chatter. Yeah, go ahead.
I just waiting.
See, this is what
I was waiting the right moment for people to pull it out.
A new one?
Yes.
Jeez.
Yeah, I did. Yeah, I wrote this post last night about being in LinkedIn witness protection, because I got comment banned again for talking too much to people. Apparently that's not what this platform is for. Don't talk to anybody. Just sit down, shut up, and be quiet. That sounds like healthcare, right?
I didn't know that was a thing.
Yeah.
I know you've.
Oh my God! Yes. Oh my God! Yes.
Before,
Read the comments under that post. There's so many people that have been through this, and I actually said, you know what? I'm going to send anybody. I will do this. Anybody that wants to know how to do this mugshot of their own photo, send me a DM saying mugshot, and I'll send you the prompt to put into ChatGPT, and it will tell you exactly how to do it. I think if we flooded LinkedIn with our mugshots and a little story of why we were comment banned, I think it would just blow up. I think it would honestly just be so fun, because we're all in this together, and on a platform that's meant for talking and networking and sharing ideas and innovations to be shut off and told
to shut you up. Shut you up.
Yeah. It's just, no, you can't do it no more. You're done. You're done.
No, I want to say that LinkedIn forgot that you are superhuman, by the way, that you are a nurse and you are superhuman, because the thing is,
exactly right.
And
I think all nurses are superhuman.
Exactly. I really want to thank Kimberly, especially for the past few weeks, because I'm busy with this move. One of the beautiful things of this podcast is that people engage in the conversation with each other. But one of the things that I have to thank Kimberly so much, not just because she's my co-host, it's a very important thing, because otherwise probably I wouldn't have done this by myself. But she's comments a lot. She keeps the conversations going on. And this is beautiful, because people is what it's all about this podcast. So is important when you continue the conversation. LinkedIn doesn't like too many comments, so ban Kimberly sometime. But anyway, but what she says is important. This conversation going on so much in the LinkedIn comments, especially, or in the DM, because sometimes LinkedIn, we know, is a platform for professionals. So manager may watching, so not everyone is intended to want to comment publicly, but this conversation going on DM, and Kimberly witnesses this very much. This happened to me as well, but
which speaks volumes.
Speaks volume about the issue. About the issue, yes.
Agreed. And I agree with you. Kimberly is
going back to what I was saying. Yeah.
Sorry.
No, thank you guys. I appreciate that. Sorry, I didn't mean to cut you off, Brittany. That's the thing with the 30-second lag. We tend to talk over each other, and that is not intentional ever. So please don't think I did it. But going back to what I was saying, I feel that there is so much visibility on what's broken. We brought it to leadership. We brought it to the organization over and over again. And for whatever reason, nobody's listening. And I don't understand that. They talk about wanting to provide good healthcare. They talk about wanting good patient outcomes and these Press-Ganey scores and patient safety and da-da-da-da-da. But do they really?
Right.
Do you really want to know?
That's the question. That's
my question. Do you really want to know?
Right.
Because I really don't think they do.
Yeah. And I've had that thought cross my mind multiple times. And I think is exactly right. And that's the problem. The problem isn't silence. It's that repeated frontline experiences often remain anecdotal and just isolated. The goal is the goal of NurseCapture, at least, is to turn those recurring experiences, into a pattern that the system can then see. So, and once they can see it and see the data, and then maybe they can see how it might affect their bottom line. That's my hope eventually.
What you just said is the $1 million answer right there. How does it affect their bottom line? But is it going to change anything? Because we've been preaching to the choir for how long? We've been talking to each other about this for how long? All of the workarounds, the making something work, and borrowing from another unit because we don't have it on our unit, or beg borrowing and stealing throughout the organization because we needed something and didn't have it. And then all of that communication breakdown. There's all of that time spent where you send a message to something and you hope that it does something. You hope that it goes somewhere. You've raised a concern. It's not a complaint. It is not a complaint until the concerns are just not being heard. And how many times have we done that? And we've said, look, this isn't working. We got to do something different. And you, as anyone as a unit manager, and I am not bashing leadership. I absolutely think there's great leadership and there's poor leadership. I mean, there's good nurses and there's bad nurses. There's good people and there's bad people. I mean, you could beat that to death. I'm not, arguing that. But what I'm saying is, if you see this every single day in your department, you see this struggle every time you come to work, not only in your department, but in conversations with other managers and with other leadership that, they're feeling the same kind of thing. People are bringing these concerns to them. Why are you sitting on them? If you are one of those who's trying to go to the top and to get answers and to fix it, you're in the struggle just as much as we are. But my God, you guys, healthcare, nursing, this profession, there's over 5 million of us. How can 5 million people not make a difference? How can our voices keep going unheard and not making a difference? Why is nothing changing? Why are we leaving? Why are new nurses burn out in the first year? I mean, I could go on and on with my questions because it's just like you said, it's just happening over and over and over. And it takes an amazing nurse like you to create something to try and capture and to show them, because it seems that once you put it in their face and this is how it's affecting your bottom line, that ROI, then maybe something changes. Once we hit their pocketbooks, then it changes. But look at everything that was damaged and broken and really broken in the meantime.
But if you remember from our previous conversation, and tell me if I'm wrong, if I remember wrong, we touched upon these things. We said that actually all the questionnaire or the survey, they're made to basically prove a point, that they may in a way that they have some data, but not all the entire data. And also, there are so many research that show that survey are not completely answered truly, meaning people tend to not answer certain question or make them feel less heavy because they are scared of repercussion. Because at the end, the survey, yes, they are anonymous, but there are ways, if you will, there are ways to actually identify people through surveys. So people, nurses, everyone, when answer this kind of survey, they are not, they don't really feel comfortable. And in the majority of the case, they pushed to answer a survey. It's not a free survey. They have to do it. And when they do it, they're scared to do it. So the data collected is actually not real data. First. Second, I remember we said that or maybe it was a thought that I had after our conversation. I'm not sure about it. But yes, that these surveys are made to basically prove a point, prove a point. Because, for example, equity, diversity, inclusion, right? You have all the thick done, so you are an organization who has all in place for diversity, equity, inclusion. You come out with a survey with certain questions, people answer back, okay, see, the data say that our hospital is very good. But when you go on the floor and you leave your 12-hour shift, you actually see there are racism behavior, the bullying behavior is not what's actually come out from the data, from the survey or from the 10 trainings that you do to leadership, from leadership to a front line.
Yeah.
So I think that this is innovation is very important, because capture the very day by day, even the passive aggression between colleagues, so between manager and the staff, or between, they do, we talk about this, Kimberly, several times. They do also patient satisfaction questionnaire, right? So of course, patient reply sometimes even depending on their emotional status at certain moments. And if they had a terrible day because maybe they have an argument with their family member for some treatment, right? They don't want to go through a treatment. The family member pushed them to do the treatment because they're scared to lose them. So hard time for this person. Always provide a beautiful care, amazing care, but because it's the moment the patient feel the form, patient satisfaction form, is in a state of mind, anxious, agitated, whatever, it's ending up giving a negative response. So while this innovation is very good because you capture day-to-day, minute-by-minute conversation. My question, I think, is who owns the intellectual property? Who owns the data? How can we go over the sensitive information of the patient? So I'm very curious, because I'm in a part of the NHS Clean Entrepreneur Program, and I'm in connection with all these amazing clinician innovators. And one of our problem that we face and how overcome intellectual property to make that the innovation is ours, because we designed, we created, and so we want to own the ownership, and not the hospital that actually give us space to develop the innovation, but also how to manage the sensitive data of the patient and all the or the colleague, co-workers, all of that.
No, yeah, that's a very, very important point, and one that we're really, it's one of our core kind of like founding principles that we kind of integrated into NurseCapture. And it's been one of the, so anonymity, right? Because just as you were talking about with these employee engagement surveys, no one answers them truthfully, right? Because even though they say they're anonymous, we all feel they're not, especially inside these large institutions. We know they can likely trace it back to us in some way. So no one's honest. No one's really going to give their true, what they really think and what they really feel about what's going on, especially when it comes to like a toxic workplace environment. I know that too, because in one of my places I've worked, we actually did an anonymous survey. It was truly anonymous because we created it through a third party, and we got really real responses. And it just kind of was kind of showed me that there's, that's what it is. It has to be absolutely anonymous, and not just nurses need to feel and know that it's anonymous. There needs to be that level of respect and trust that it is. So that is a foundational principle when we were building NurseCapture. So that's one of the things that we keep coming back to, is how do we ensure that when nurses complete, so right now we're doing a validation sprint. So we're just trying to figure out a couple different ways, again, very lightweight. We don't want to make this more something more for nurses to do, but at the same time, we need to capture the data, right? We need to capture what happened. Like tell us. So the way it's currently right now is just tell us what happened. Think about your shift. This is where Kimberly posts something about this. Think about your last shift. Was there a moment where you had to compensate, find a workaround, something that was not a part of a usual kind of day, right? And then we make sure to say this is anonymous, and we've tried using different validation codes, so that they're kind of like an authenticator code, where it's just recycled or it's just tied to one person or whatever the case may be. And so we're trying to figure out the best way to make sure that nurses know that when they take this and when they submit this information, it's not tied to them. It's not tied to any individual. At the very least, the data that will be collected will be at unit level. So there's no individual person, because at the end of the day, what we're trying to collect is that data about working, all those workarounds, all that extra stuff that we have to do, patching the cracks, the days that we are orienting somebody and then we have to take on, another student or take on another, it's just all these, we could go on for days and talk about this situation. So those are the moments that we want to capture. And those are the moments that we, and we want nurses to feel that it's completely, there's no name, there's no patient identifiers. It's just the data itself. Tell us about the event, and that so we can extract that data and then put it into the system and, hopefully compile and see what we get and see if we can find patterns that emerge. And then hopefully we'll have some quantitative data to finally show the invisible work that we do.
So I have a question real quick, Brittany. So when we talk about the workarounds and we talk about what data it's going to capture, are we looking at, say, starting your shift and somebody called in? So now you're trying to figure out how to disperse their assignment. Yep. Or you're headed down the hall to see your first patient and there's a call light on, you stop to answer that. Is it kind of all the stops and goes in a day? Is that the kind of data that you guys are trying to collect and see exactly what part of that could have changed, how that could have been different for that day, and look at that data as, okay, this all happened because they were short staffed. This all happened because there was a demise or a code on the unit, and now everybody is trying to decompress. All of those kinds of things. So that's, I guess, is my question. That's what's going around in my head.
Yes. So you're a charge nurse. You're getting ready to make the assignment. You've been working on the assignment for 4 hours, right? Been working on the assignment for 4 hours because you had to leave for multiple different things. It's now 5:30 and you have a call out. So you have to now go to your sister units, or, call my goodness, I'm losing my words, the staffing nurse, and say, I need a nurse. And then, so let's say they give you a nurse, but then let's say you have another call out right before 7:00. What do we do? Right. So it's those kind of like where your mind has to reprioritize. So and within those 5 hours that you started making your assignment for the next shift, right, you've been interrupted multiple times, whether it's the phone, whether it's taking care of another patient from one of your nurses, whether you're running a pharmacy to pick up something. Those are all interruptions. And then when you finally come back, you have to reprioritize. You have to think about, what was I doing? How many times do we have to do that during a shift? All of that takes mental and cognitive effort, a lot of it. And we just do it like that. And I think that, one, it speaks to our level of adaptability. But at the same time, it's also leading to overwhelmment. And that's why you leave, at least for me, I was leaving at the end of the day, just like completely exhausted, but almost feeling like, what did I do? Because you're just doing all these little things so much. And but yes, that is the goal. So, and it could also be, if you experienced workplace or, lateral bullying or violence from a patient. We want to measure and capture all of those things, all of those events.
And if I could make an example, so we are implementing now Copilot in our clinical writing and things. Copilot. We are about to launch Epic. And as a team, for example, we've moved building twice. I mean, we changed building, one for office, one for the education, that we do twice. And we still go in and out from one building to another. Plus, because they put Copilot, they're about to launch Epic. The computer that we got, they are basically, the majority are underpowered. So we constantly have to overcome distraction from many fields. The patient that called because forgot the appointment or want to change the last minute, or another patient that called because got confused with another pain clinic. The problem with the computer IT, because it's on the power, just needs to a new software to be downloaded or updated, whatever. And then they ask us to go to Epic. So we need to do all this new workshop and training and things outside our work. So all these things, they are very distractors. And I think that recording was happening 12-hour shift. Even things that don't have anything to do with our clinical work, I think they can give a very important screenshot of what are the structure and how to fix that. Because sometimes organization too, like in my case now, they do 100 implementation all at once. And how can you think that as a nurse specialist, I can focus on my work, on my patients, all these updated, all this movement, and I have to remember everything, and I don't really have time to go and grab a coffee. Well, I can't lie. This team I'm here, the way the work is done, I have access to drink, but until I work in ICU or I work in research, I didn't really have time for drinking water.
Right.
You know, so I still understand what is difficult. Go through 12-hour shift. Plus, we are understaffed. Plus, people are becoming chronic with comorbidities, so patients are becoming complicated. So there are layer of destruction on top of our work that they're not documented.
Right.
Or they're not seen from outside perspective to make people understand that this is not a good plan and we should do something else. So I'm very interested in this innovation. But yes, I think what do you think is big problem could be of implementing this innovation?
What could be a problem of implementing the implementation of this?
Because we talk about, maybe, as Kimberly said, maybe leadership don't want this innovation.
Yep, and that's potentially, could be. I think the goal, though, is, I think, to just, again, taking it and turning to an experience into actual quantitative data, into a pattern that they can't possibly ignore. Because I think that's been one of the issues with nursing in general, is that a lot of it can be considered subjective, right? So and nurses are just expected to do certain things, but it's gotten to the point, just to your point, patients are living longer. There are a lot more comorbidities. The patient ratios have gone up. The turnover is real, and we're losing experienced nurses, and it's just becoming more. It's like more and more and more weight. So I would think that as a healthcare system, if you care about your bottom line, you care about money, right? If we're profits over people, then it costs roughly, was it $69,000 to hire a new nurse?
Yeah, roughly 70. Yeah, but depending of the healthcare system, but
right, exactly. So instead of spending that money to hire a new nurse, because you have nurses just walking in and out the door, or or travel nurse or what have you, why don't we invest it into keeping your staff, right? And keeping them, not keeping them well, but also potentially, making sure they're not getting to the point that they're burnt out and that they're leaving. So this NurseCapture is really at its core looking at it from an upstream approach, right? We want to know why the nurse is leaving. We want to know what happened up here, right, before that event happened.
Do you think, sorry, this is very the entrepreneurial mind now, I think. But Kimberly, go ahead, jump over if I grumble you, or do you want to say something else? I think this is entrepreneurial mind. So do you think it's more about a pitching or who to pitch? Because, for example, is this going to help nurses because we want to retain them? Do you think this is something that when the minimal value product is implementing, you have the latest version that can be put on the stream, on the market because it's good to go? Do you think it's something that nursing can actually demand as, I don't know, for example, they can demand infection prevention control protocol, something like that? It's about a pitching, or who to pitch, or when to pitch?
Yeah, all good questions and all still to come. And I think that's, we're, again, at NurseCapture, we're still asking questions too. We're still, like I said, we're in a validation phase. We're trying to figure out really the best way to collect the data, make it, we're going back and forth. We want to make sure that nurses feel absolutely sure that it's not affiliated with their workplace or any organization. It is strictly just tell us about your day. Honestly, tell us about an event that happened and give us as much of that as possible. So you can please give us all the events that you can. That's currently kind of where we're at the moment. But as far as where it goes after that, that's the exciting part, because I hope that, I would like to believe that maybe healthcare organizations would want that data to see kind of how their frontline is doing. And then they can see in actual, maybe in real time, kind of what's going on. And then they can say, oh, this unit is experiencing high intervention or high interruptions. It seems like, the front line is they're in the orange approaching red. Let's send them support, right? Potentially. That's just like something off the top of my brain. Or it could be an organization that comes in and says, we want to implement this because we want to protect nurses, and we want to, ensure that their well-being is, intact. And so I think that that piece is still to come, and very interested in just kind of looking at all potential aspects.
Well, if you were in UK, probably Prof. Tony Young, for sure, will like to implement your innovation. I may be able to connect with someone, but let's just do it on LinkedIn and chat each other. We got a lot of comments going on. Kimberly.
Okay.
I show a few hello, people show it up, but I'm telling you, we have people from Florida to Nevada to Canada to Zimbabwe to Philippines. Where do you want me to start? UK, so many people. Tanzania.
Is there a theme? Is there a recurring question?
Is what I'm trying to see, and many are also replying each other. Kimberly, any suggestion?
Oh, I see some.
Prof. Lily from Singapore. Hi, Lily. Thank you for showing up.
Yeah, let's see. I think just start putting them, just go up and just put them up there. And then when we come to a comment that is related to what Brittany's talking about, what we're talking about, because the beautiful thing about the podcasts and the comments is that everybody shows up and they start talking to each other. Pretty soon they're answering each other's questions and they're mingling and spreading love. And I love that. I find myself doing that in a lot of the conversations
each other
and podcasts as of late. Yeah. So people are just talking to each other and, hey, how are you? How you coming in? Mm-hmm. Thanks for being here. Oh my God, it's nice to see you. And I love that. I love that the village is growing. And I love that people can just come, they can show up, they can meet one another, because a lot of times, you guys, especially in the list that you just stated, Dina, across oceans, across zip codes, people are just meeting one another. And that's the beauty of LinkedIn. Yeah. I will say that as much as it gets on my nerves sometimes and it shuts me down, and other people, I mean, that happens a lot to other people as well. This is the beauty of it. These people, I would have never met otherwise. These people, I would have never had these conversations with. I would have never met you. I would have never met Dina. We would have never been here in the first place. So there is a lot of beautiful things about this platform. As much as I get annoyed and as much as other people get annoyed, there is a lot of beauty to it. And it can be beautiful and brutal. Just like healthcare, right? Just like our profession, it can be, can be beautiful and so. In all of the comments and people talking, Dr. Dina Scott, if you find hers, Dina, it was down a little bit lower, and I just kind of replied to her. You can keep going down under where you are now.
This one,
and yeah, because she said we are so accustomed to getting it done. We don't memorialize what it takes to get it done.
Yeah, that's
true. That goes back to what we were talking about. And nurses, we just figure it out.
We just figure it out.
We figure it out. We get it done. We bypass the, let me call this person. Well, maybe this person knows. We start talking amongst ourselves, or we just do that math ourselves. Like, okay, all right, let's see.
Yeah, we're problem solvers. So,
MacGyver. We're MacGyver most of the time.
Yes. And I
so Dina, thank you so much for showing up and sharing that with us, because you're absolutely right. We always do just figure it out, but there has to come a time when there isn't anything to figure out. It's figured out for us, right? You just come to work, you put your best forward, your best foot forward, you give good care, you have a good day, everyone's taken care of, and that's a good day. But it shouldn't have to be a constant struggle to, I have to figure this out today, or how's this going to work? Or like you were saying, when I remember when I worked night shift and would sit with the charge nurse on nights. And I think you were trying to think of house shift supervisor earlier when you were talking about who called to get it. Yeah. And so one of my best friends was house shift. We always called her house shit supervisor instead of house shift supervisor, because she was dealing with all the shit. But I remember those nights sitting with her and trying to figure out the staffing, and then it only takes one monkey wrench being thrown into the whole mix that throws it all off whack. And then there comes that time where now you're having to reach out to another unit to steal from them a nurse to fill that, or you're digging through all of your on-call people, but how many people actually want to answer their phone on their day off, or they know the house shit supervisor's number and they're like, oh, not answering that. No, silent. No, didn't see it. And, but it's all of those little things that happen, like you say, in a day that just throw it off. And when people are called and you find out, it's happened to me so many times where, you're going to be floated to so-and-so because they need help or whatever. And if we need you, we'll pull you back. And I don't know about you guys, but that always just threw my whole day off, because you come in all prepared, all prepared for your day and what you're going to do and who your patients are. You had the same people yesterday. You're hoping to have those same people today. And now you're like, oh God. And then, especially if it's a unit you've never been to, or if it's a specialty you have no clue. Like I got floated to the secure unit one time. Dude, I was terrified. I'm like, oh my God. What am I supposed to do up there? I'm thinking this is just going to be an awful thing. But I will tell you that the nurses there were so amazing. They were so grateful to have that extra help that they eased all of that very quickly. And to be honest with you, the inmate prisoner patients, and they're just people. I'm not labeling them. None of that. But just being a female and being floated to a unit such as that, I was just scared. I had that fear. And I think anybody who's never been there probably would have that same fear. But they were so kind. They were just like anybody else. They just wanted to be cared for. And I feel that when things like that happen, that's something else that can be captured. You've been floated to another unit. Yes. You're now into a specialty that you have to function in for 12 hours that you have no clue what you're doing. Yep. So then you try and think about all of that mentally. And then how many times are you asking the nurse that you're working with, can you show me where this is? And then now you've distracted her. Now she has to go and show you. Yep. I need to know where this is. How do I chart this on your unit? This charting doesn't look the same as on mine. That's another distraction. That's another takeaway. That's another time away from the patients. So I feel that what you've created and what you've come up with can be incredibly useful if they use it.
That's the hardest part, because we're already caught in it. We're already just doing so much just to get it done, right? Just to get it done. And it's really hard to pull out your phone and just, even if, we're trying to make it, under 4 minutes, and it's just tap, boom, tap, boom. But even still, even that, it's it's just one more thing. So we're really,
Right.
I think that it would be, so we're looking for a cohort of nurses currently. So we're recruiting just to get some initial, just for initial pilot, or we did our pilot phase and now we're doing the validation sprint. So now we're looking for more nurses just for our validation sprint so that we can then collect that data. But again, it's hard because as you're on the unit, it's hard to capture in real time. So usually, and it's usually after the shift. Again, still fine, still okay. The more data, the better. So it's just searching for anybody out there who would like to submit their events and their information, their data. It would be incredibly helpful. Just as we start, so we can show and say, like, look, there's real evidence here. There's real quantitative data that we can collect and see, and then move forward.
Yeah. So do you want people to, is there a link or something, Brittany, that you can share, maybe put it in the private chat and then Dina can share it in the live chat to where people can reach out to you or sign up to do this with you? I think that's an amazing idea. I really do. It is collecting people to actually want to contribute, but also not feel obligated. You guys, Brittany's just merely inviting you to take part in this. And I think it may be a solution. We always talk about the problems and what's happening in healthcare, what's broken, what needs to be changed. But it's innovation like this, ideas like this, coming from the nurses, coming from the profession that is actually on the ground, boots running, hair on fire, exhausted. They haven't ate. They haven't peed. They're in the break room or in the supply closet crying because they just can't do it anymore. I can no longer do this. So I just feel that if organizations honestly take this into consideration, a lot could change. I really believe that, Dina. I don't know about you, but I really believe that.
I think there will be a very big open eyes. Yeah. Eye opening. Yeah.
Yeah.
I hope that's our mission, our goal. The development team I'm working for is incredible. They have, they're the tech and I'm the clinical piece. Together we we just want to make sure that the product that we put out is, again, we have our core foundational things, which is anonymity. We want to make sure that the data that we're collecting is not, we're also being very aware of like any biases, right? We want to make sure that we're filtering out kind of, excess, things that might not be appropriately so they're utilizing their tech skills to kind of address things like that. But so that's where we're currently at. So what I'll do is I will put NurseCapture's LinkedIn page, and then only because we're still tweaking the form, and which will be available ready today, hopefully to go. So, but yes, it is. The goal is just to collect as many events from nurses across anywhere and everywhere, and just know that it's not tied to anything, and it's just really to give us more information, more data, so we can build more and take it to places. It's honestly what I kind of envision in my mind is something that is like you're something very small, maybe on your badge, maybe whatever, and you're walking down, you're interrupted, tap. That's one signal. Maybe there's something that's a little bit more like a compensation. So it's a little bit more severe. You've had to go to 3 different units just, to get the job done. Maybe that's just 2 taps and that's it, right? Just those signals alone across how many, and then you can see it all live on a dashboard, and you can actually see, a unit or, how a hospital is functioning in real time. Like, how much burden is going on, how much are they having to compensate and work around. And another thing, another aspect to this is that we really want nurses like innovations, because I feel like there is so much innovation sitting on our front line for healthcare in general, but for specific institutions, because they know have been there, been there so long. There's so many great ideas out there. And I think right now, a lot of tech companies are just kind of like taking pieces of, Epic is taking like charting time, and people are taking like badge swipes and different pieces of technology and trying to put it together to kind of address the issue. But to me, it's like, why don't you just come ask the frontline yourself, truly? Come just why are we kind of like going to these third parties, and I understand, it needs to be quantitative data. I understand that too. But at the same time, I think there's just been never really any consideration for nurses' voice, their ideas, at all. Not mostly nurses, but frontline workers. How often have they asked you, well, do you have any ideas about this? And most may not, because there's workplace, or toxic culture. So there's just so many different things.
And I think, and I pause on this comment from Kenneth, and I'll show you actually the after from him, because I think it's very important. This really resonates with what you're just saying. Kenneth say, I wonder if the research into social evolution, anthropological system of culture will be disciplines of knowledge that will help in this conversation. And I believe so. I talk about a career coach because I talk about a lot about team dynamics and how productivity change among multicultural teams, toxic teams, very well structured teams where there is transformational leadership versus disruptive leadership. So it's really behavioral science that we actually should consider at this point. And he also added to that comment, another comment, 12-hour shifts feel too long too. Like, why does it have to be greater than 8 hours with 4-hour overlapping design? Oh yeah, that involve paying people enough to have it work and enough people to want to accept the pay to stay staff. So we could throw money at the problem if it was spent properly. I can say about this, a career coach again, that depending on the healthcare system, because in the Anglo-Saxon culture, countries, you have 12-hour shift. While, for example, in Europe, you have morning, afternoon, or late. You have evening. It's more broken through shorter shifts, depending of maybe the culture, how that a kind of healthcare system works actually. So what do you think? And as I said, quantitative data, which behavioral science is most about, right?
Yeah.
But yes, team dynamics was really count, because all these interruption burden of the day by day, shift by shift nursing life, that's really it's all about.
Yeah, and that's a big, I mean, and some nurses, they like their 312s, they get their 4 days off. So I think that it's more, I feel like it shouldn't be a standard. I mean, that's just my personal opinion, but it shouldn't be like a standard that hospitals have. We've just kind of, I don't know how it kind of got there, but they just do 12-hour shifts. But I don't think it should be a standard like that anymore.
No, I think it should be tailored based on the specialty or the workflow. And I to be honest, working in Italy and UK, I've done different kind of shift. From the more short breakthrough to the double in depth. For example, in Italy, we used to do afternoon and nights. If we want to do overtime, we go through. So at the end, there are 19 hours in total, which is a long shift.
Yeah,
actually, it's not allowed in UK 19-hour shift, right? but
Wow.
it's depending of the country, I believe. But a little bit of experimentation, tailor on the floor, tailor on the specialty, or because I understand that 12-hour shifts, for example, in ICU could be useful because of the continuity of the care. You get 12 hours. But if there is so much disruption on the floor, you still don't have continuity, because a nurse can get distracted, lose focus, or maybe get tired very quickly. Anyway, should we read a few comments, Kimberly? Should I go with Lillian one from Singapore?
Yes. So Lillian says most organizations implement flexible working hours as long as employees work 160, 168 hours per month, usually in acute care. And long-term facilities, shifts are 12 hours at some places. So in reading this comment just now, Brittany, I had a thought. Have you thought about what types of organizations or facilities, clinics, are you looking at just strictly hospital for this implementation? Are you looking at long-term care? Are you looking at different specialties outside of the hospital? You know, because there's always so many subsidiaries of these different clinics, behavioral health, OB, all of these things. Because I was just thinking when she said long-term care, oh my God, in long-term care, you may have one nurse, 2, possibly 3 CNAs on a good day, and 30 to 50 patients.
Yep.
And we know how long-term care goes. We know how that goes. Do. So I won't even go into that because we've been down that rabbit hole many times and it just pisses me off. So we won't go there. But I just was wondering, have you thought about how to get it into different organizations, different areas? Yeah.
Yep. So currently it's for inpatient, outpatient, and then we have another section. So outpatient would be considered, we're considering anything like your, I would say long-term care might be out, depending on the level. You have acute inpatient rehab, you have subacute level, you have your long-term care, and then you have your clinics. You have nurses working in clinics. So it's for across the board. It's for all units inside inpatient level, all specialties, and on the outpatient side, and for everything else in between.
Yeah, I think once you've got a minimum value product that is basic for every kind of clinic, you can implement it, you can tailor it for any kind of. I would like to show, just before continuing, is a very, very good conversation, long conversation. What did we miss about this conversation, Brittany? Do you think we should talk about?
Let me see. I think we hit on a lot, which is great. And
which
again,
is great,
can't thank you guys enough for having me back to share what we're building here. I'm so excited about it. And I think, and I'm just so grateful for Kimberly, for Dina, and for all the people I've had conversations with through LinkedIn and otherwise, because I've met so many different so many different wonderful humans and nurses and people from all different backgrounds, and I feel like we're all circling the same problem, right? Just from different angles. So it's been really wonderful to kind of absorb and hear all those different areas, because it's just helped to shape this work. So I think I'm looking at my little kind of cheat sheet here of things I wanted to share about NurseCapture. And
if you don't mind, if you're searching, I'll show the community while you're searching, or you find it already.
No, I found it. So I basically,
go.
I think the largest piece about this is that, at the end of the day, we're all talking, we all know about burnout, and we all know the reasons why. And like we were just talking about them earlier. And I think I just was like, I'm so tired of talking about burnout. I'm so pissed that another nurse is coming in like I did 2 years ago and saying, I was treated this way. I am just, it's a constant revolving door. And I just got to the point, I'm just like, how can we change this? And so that was when I actually saw someone reached out to me, and we just started thinking and just started developing, and then just more people started reaching out, and I started learning more, just doing literature dives and this, and the data supports it. The data is out there. It supports that something is needed that is going to instill trust in nurses to be able to provide the truth about the work that we do. And then we need a good way to actually measure that work, or else I'm concerned that, going forward, when I need care, I don't know if there's going to be,
a nurse
there to care for me. So
I agree.
it.
I think we share the same vision on why at the end.
Yep.
That we do what we do, all of us in their own specialty or interest or passion, because we can see how the nursing profession is draining out. Less and less nurses for a population who's become more and more demanding on global level, not just on the Anglo-Saxon or European countries. So
Yep.
I think we are all moved by the fact that we have to find a solution. If leadership doesn't understand or doesn't listen, and I think they don't listen because they actually don't understand, because this is a money problem as well. It's a big money problem too. So they don't go through it because they don't understand. So they don't listen because they don't understand. They think that it's a different money problem, so they try different solutions. So I think that showing them the right evidence is so vital to make solution. It's like, just like me, for example, I started to talk about international educated nurses, all the problem that can happen and occur if international educated nurses are not supported as they should be. I started talking about this in 2015 and really become very vocal in 2019. And now, at least in UK, we 1/4 of the register in UK, they start to talk about international educated nurses just this year. So I think these conversations these innovations are important because they need to be, reminded and talk about constantly. And I thank you for coming in today again to our podcast to show the amazing work you do, and also what you already grow and your innovation growth from how many months you've been here? 3 months? When did you come?
Oh gosh.
3-4 months. It's not long.
It's been, I can't remember how long. It's been a wild year, I'll say that.
But what I'm saying is that you're growing so quickly and you are producing so much in your innovation. In few months you're already gone through the minimal viable product, the pilot program, all this stuff. So I think it's amazing, Kimberly, isn't it?
Yeah, and it's a big testament to my development team. They're phenomenal. They'll send me something, and then I'll say, we need to, can we tweak this, tweak that, and they'll have it back to me like the very next day, and it's everything and if they just been great. So I really feel like that's a testament to them. And I think just one more thing about all of this is like, healthcare has become extraordinarily sophisticated at measuring the worker. And I'm interested in whether we can become equally sophisticated at measuring the system the worker is responding to. If we're trying to, looking from a data perspective. So the current workforce asks, like, where was the nurse? I want to say, they say, what did they document? How long did it take? How efficiently were they deployed? But what we're asking is what happened? What did the system require you to do? Why was that necessary? What changed because you intervened? And does this pattern repeat? Because, yes, healthcare frontline workers, our job is to save lives. But also, that's another piece of it too, is let's also give feedback and show nurses and frontline workers, like, this is despite all these interruptions and all these compensations that you went through this shift, we saw good outcomes. So that's the goal.
Okay. Kimberly, you shared this one. Sorry, I'm covering you. Do you want to talk about this one, or you wrote in the comment to leave the conversation?
Yeah, so I meant to ask her this. So, and it says Brittany. So, and if you guys see me not paying attention to you, whatever, the only way we can comment in the comment thread is from another device. So I'm using my phone. So if you guys see me looking down or whatever, I'm trying to stay in the feed and talk to people at the same time as being here and being present. So I'm multitasking. I'm figuring it out.
Amazing. I love you.
You're the best.
Trying to figure it out. Anyway, so I meant to ask you this earlier because Catherine Schaefer, I don't know if you saw her comment on the post earlier. She had said something. And so I wanted to ask, who owns the data and what are they allowed to do with it? Because visibility cannot become surveillance. We cannot uncover the work nurses are doing to hold systems together, only to turn around and use that information to measure how much more they can carry. So that was something that was kind of rattling around in my cage today after seeing your comment, Paoloni, Manfredi. She had also, Paola, I always say that wrong. Her, you, and Catherine were all in my comment section this morning. So I was trying to touch base on each one of you before the podcast. I just didn't have time. So I did respond to Catherine. And if it's okay, I'm going to read what Catherine said based on NurseCapture and what we were talking about. Okay. And then I'll tell you what I said. And then I want you and Dina both to kind of dive into it because she said something very, very vital. Okay.
No, so absolutely.
I'm going to swoop. All right. I'm swooping. I'm multitasking. I'm figuring out how to get it done here. So let's see. Let me go back to this. Let's see. Take me just a second just to maneuver to this other screen here so I can find it really quick. But it's like, oh my God, seriously, we're all talking about playing. It's like standing in a bar and playing a dart game. We're all just throwing darts and we're all hitting the bullseye. But it's like, who's paying attention? Are they paying attention? They really want to hear this because they keep asking us to talk, to speak up, to ask questions, to do these surveys, to complete all of this and give them data. But honestly, where is that data going? And are they really listening?
Right.
And if given this type of data, what are they going to do with it? So that's another thing. So I'm almost there. Let's see. Okay. So Catherine said, the measurement problem has a second half worth, let's see, in my computer, it's like not liking me StreamYarding and this. Okay. Second half worth putting on the table tomorrow. Once this work becomes visible, it becomes attributable. I can't even say that word right now. And nurses have landed correctly at being measured, usually being managed. Every documentation burden in healthcare arrived promising to make their work visible. So the design questions is who that data belongs to and what allowed it to be used for. Signals a unit can see that an act is one thing. A count of interventions per nurse that lands in an operations dashboard is something entirely different. And the only way one of those makes nurses want to report. The other half is what leaders are supposed to do once they can see it. A system that measured compensation without redesigning what requires it just proves that nurses can observe more, then it hires accordingly. And she says, ask Brittany how she is protecting against both. is if she has thought it through, that is the most interesting part of the whole thing. So that's what she said. And I know I just kind of blurted that all out, but
That's a
I
great
had
question.
said to her, I had said to her in response that this is the part that, yeah, right. I mean, her mind is amazing. Anyway, if you guys do not follow Catherine Schaefer, I would highly recommend that you do. So she said that,
Yes.
I said to her, this is the part that could turn a good idea into something dangerous if we don't get it right. Visibility cannot become surveillance. The minute we turn it into nurse A prevented 1.17 failures this month, while nurse B prevented 9, we have completely missed the point. We've taken evidence of system weakness and converted it into another measure of individual performance. Worse, if we could teach the organization exactly how much dysfunction its nurses are capable of absorbing, I want to know where compensation is happening, because the compensation itself is information about the system. What keeps requiring a workforce, a workaround that where a nurse repeatedly bridging gaps, what almost reached the patient. What are people quietly fixing too often that are mistaken for their vigilance for a functioning process? Mm-hmm. The unit needs that intelligence.
Yes.
The nurse should never become the metric.
Never.
And that's what I think what we're talking is, we shouldn't ever become that metric. You know,
exactly.
What NurseCapture is capturing, I think, is profound. Exactly. And it's something definitely that needs to be implemented. And I think also that it's going to take all of us, you guys. We talk about this all the time. It's going to take all of the nurses collectively to come together and really put our heads together, because we are on the front lines. We are in the clinics. We are in the physicians' offices. We are in the homes, home health. You have home health, you have the clinics, you have the hospitals, you have so many subsidiaries of all of this. There is so much information that can be collected that can probably change a whole lot of what's broken. But like I said before, these organizations are going to actually have to want to use it. They're actually going to have to listen to what we have to say and what we're presenting to them. If it's going to continue to just be all about the ROI and all about how much money an organization can make, then where are we going? What are we doing? Mm-hmm. I feel like we're going to be right back at square one again. I feel that that's what's going to happen, is that we're right back at square one. Agreed.
Yeah. And
hi, Dina.
Don't know what's happening.
What happened?
It's okay. It's okay. I think I can still hear her. There she is.
There we go.
I do. I would love to speak to Catherine's question, because I think it's a profound one, and it's an important one. And again, it's one that, as we've been designing NurseCapture, it's one I keep coming back to myself, because I know that I know how all of that feels, and I will not participate in any survey that I think will be come back to me, will be given to my manager, will be given to, to risk my job or anything like that. So, so I think that it may be one of the most important design questions we're wrestling with, because she's right. The moment invisible work becomes measurable, it also becomes potentially attributable, he said that, and potentially manageable. And the last thing I want to build is another tool that gives healthcare more sophisticated ways to measure nurses. So the unit of inquiry for NurseCapture has to remain the system condition generating the work, not the individual nurse performing it. So if 5 nurses are repeatedly chasing the same missing information, I don't want leadership asking which nurse spent the most time chasing that information. I want the system asking, why does this information have to be chased at all? So I think, and that's why anonymity isn't just a privacy feature for me, it's part of the philosophy of the product. We're trying to aggregate these experiences into patterns that reveal something about the operating environment, not create individual productivity profiles. Again, that's just such a profound piece of NurseCapture and like what we're doing. But there's another risk. What happens if we successfully measure all of this and organizations simply become better at quantifying how much nurses can absorb? So if NurseCapture tells you, excuse me, that nurses compensate for the same system condition 400 times this month, and your response is to staff around the compensation rather than investigate what's producing it, we've just made dysfunction measurable. We haven't made the system better. So eventually the question can stop at, what are nurses doing? It has to become, what is the system going to do differently? Because we now know this. And that's why, again, so who owns the data? NurseCapture and the company owns the data. And depending upon where we believe authentically, like whose hands it will go into, if that's going to be an organization that's going to potentially utilize it to target nurses and do that, then that's a non-negotiable for us.
Yeah, because I can't remember the incident, but not long ago, I think maybe a couple of months ago. And this was, I think, a post from Love. I can't remember her name. Was an incident where basically an organization gave to nurses a certain device. I don't know if it was a wearable or was something the stationary, and they collect some data to improve productivity, etc. So they collect all the data and they create this software, and basically they were able to fire a few nurses because they created this software that improved productivity. So and basically nurses help them to collect data and create this application software, whatever. And with this application, the same nurses who help them create the software.
That's awful.
Yeah, it's awful. So I think this is important things to consider. By the way, I put the link of that comment, Kimberly, that you read. I put in the comment. So it's on LinkedIn though. I put in our LinkedIn live. I couldn't do on YouTube. I'll try to do it anyway. So guys, whoever want to read, you can go to that comment and post.
Yeah, it's under the announcement for today's post. And like I said,
I put the link.
Paola and Brittany both had also been, look at me changing all my glasses. Yeah, it's like, let's see how many pairs can I find here. I'm struggling today. God. Anyway, yeah. So it's under that announcement for today's or yesterday's announcement for today's podcast. But
yeah, there is a link.
I just hope that other nurses and everyone that is watching this today, I want you to take that takeaway today and think about what it can capture, the ramifications of what it captures, what problems it can solve, and then also what problems you think can arise from using it. I think that's what the collective needs to be. I think that's what the brainstorm needs to be. All of us putting our minds together. And good morning, Sunshine. I haven't seen her in a while. But I think those are the questions. I think that's where we can all come together and brainstorm and kind of maybe help you with NurseCapture and maybe the things that you didn't think about and things that the implementation team didn't think about. And speaking of that team, are they clinical? Is anybody on that team that's implementing this with you? Are they clinical? Do they have any background in that to where they can feel and actually see what we're seeing and why this is so important?
They do work for other clinical companies. So they There's nobody on the team that's actual clinical, but they do other work for other clinical institutions. So they're all
That was just something.
tech. Yeah.
Okay. Yeah, that was something that was rumbling around in my head too. You know, because you have different areas of telehealth and AI systems that are being utilized, and nobody's clinical on the team. So in my mind, I sit and I think, how can you feel what I'm feeling? How can you understand what it is, the concern that I'm bringing to you, if you've never done it, if you've never felt this?
Exactly.
So,
and that's why I like
truly.
Sorry, me cut you. That's why
I'm sorry. The 30-second lag.
I know. That's why I love our team so much. It's Revivo Technologies, because they basically say you're the clinical, SME, and we are the tech. And they have taken every single clinical consideration that I've given them, and they've been so thoughtful about it in the way that they've integrated it, because again, these are the foundations: anonymity. We're not measuring the nurse. It's, and they've maintained those core foundations. And then anything that I've given them, any clinical scenario, perspective of a nurse in the front line, they've not only just like changed it, but they actually think about it and how it's going to apply to the software itself. So they've been fabulous, and I'm very grateful that we're in collaboration. But yes, to your point, it's going to take all of us. And part of the validation sprint is gathering feedback about the form itself. So would love to hear people's feedback and suggestions, and how do we improve this? How do we make this better? How can we really get the data that we need?
Yes, and I want honesty. This is not your employment survey. This is us having these conversations. And if we keep hiding behind the truth, you guys, we're not solving anything. If we don't feel that we can come together as a profession, as a team, collectively, and be honest about what's happening, nothing's going to change. Nothing's going to get fixed. So I truly hope, and if you don't feel safe enough, because I know the golden handcuffs are there, please just send us a DM. We can have these conversations privately. And that's always our goal, is to protect one another. We get it. Yep. We get it. And linking is also funny like that. There's those people that like to stroll and scroll and dig up dirt. So I get it. And a lot of people a lot of organizations really don't want honesty. They pretend they do, but they don't. And then when you come to it, we know how that goes. Then you're labeled, you're tagged, you're whatever. We know. But it just made me think, and having this conversation with you too, you may be onto something, because you think about what this can do for a nurse who's taking care of a human being, a doctor, a respiratory therapist. Think of that whole organization.
Yeah.
Not just being just nurses. Think of how big.
Frontline. Oh, yeah. This is applied for everything.
Think about how big that could be. Okay. In our profession, in the healthcare industry.
Yes.
Girl, take that outside of the healthcare industry. What if you put that in logistics?
Yeah.
What if you put that in law enforcement? I mean, I could go on and on and on. You think about all of the other industries where we have so much communication breakdown. There's so much of that. Everywhere, every industry. And, also something for patients. What if it was a tool for patients to use and communicating? Because my chart, as good as it can be, it's a hot mess. It really is. Especially when patients are getting, like my mom is going through a lot of stuff right now, and God bless her. Please say prayers. But she sees results in my chart before the doctor sees it. So of course then she's calling me and she's all freaked out, and then she's Googling it and WebMDing it. And I think that happens with a lot of patients. A lot of patients are seeing information, results that their doctor hasn't seen yet. So then they're jumping to conclusions. Then we have that fear that constant fear, and how do we navigate that? There's just so many things. My brain just never shuts up. That's why I'm comment banned, because it's always working. But it's just, it's like spinning and thinking of all of the ways that it could make so many industries better if they actually implemented and secured the data that they're receiving. Do you really want to be better? Do you really want change? Or are we just like everything else?
Yep.
That's my fear.
That's
my hope and my fear.
Agreed. I hope it's I think the former was to change and to want to know the information, to want to restructure your whatever to help your bottom line, also help your staff, let's actually do something good with it. So any data that's collected through this validation sprint, or even moving forward, is always going to be owned by NurseCapture. That's it. And if companies want to, use it in a way that's going to actually produce, it's got to be unit level. It's not individual targeted ever. So, but still don't, more to come. I don't know. And that's what's so great about it. I don't know where it's going to go, but it's here and it's available. And I just want to collect as much data as possible.
And this is beautiful. And this lean methodology is what works best, the scientific method. And I think we challenged you quite a lot today, Brittany. Today, me and Kimberly asked so very challenging question, not to put you on the spot, but actually to validate that you're there.
Yes.
So good.
No, I
we really
it.
believe in you. Yeah, we really believe in you. So
thank you.
I think we are happy. Yeah, Kimberly?
Oh, yeah. Let these people go, for God's sakes. Let Brittany go. She's probably has something better to do on a Sunday.
Exactly.
No, God.
It just now started pouring, so clearly I'm not going anywhere today. So.
It's very cloudy now. I'm going to lie down and watch something on Netflix.
Oh, yeah, because you're 4 hours ahead, Dina, or are you 5? I never remember.
5.
4?
It's 5.
5 hours. Yes. Yes.
5:45.
Yes, I highly recommend naps on Sundays. Sundays are nap days. Absolutely.
Yeah,
they should be. Thank you so much to both of you for having me back.
Thank you for coming.
A pleasure as always. And thank you, Kim, for your voice, for your support.
Of course.
And Dina, to you as well. Thank you so much. I can't thank you both enough.
We love you, and I can't wait to see where this goes. I really can't. And I hope that what I said puts a bug into other people's ears to reach out to you. And honestly, to see where this could go for other industries, because I do think you are onto something. But again, those people have to want to make it better. You have to
get
want
ready.
It better.
Get ready for another episode in a few months' time, so you can update us from all the implementation.
Yeah.
What do you think?
I hope so.
Thank you very much. It's lovely to have you here. Thank you very much, everyone, to come and watch and commenting and be part of the conversation. Just a little spot. If you want a successful global nursing career, think to join our community. We are supportive each other, and we give all the tips you need for your career design and next career move. Thank you, everyone, to come in. We love you.
Thank you. Love you.
In 2 weeks, into Sunday time. Bye. Thank you.
Thanks, guys. Love you guys very much. Have a wonderful Sunday. Thank you, everyone, for coming. Go to bed, take a nap, go to party, go sunshine, whatever it is you need to do for the rest of your Sunday. Enjoy. You are now set free.
Bye.
Bye.